Hey guys, I know I look a little bit different, but that's okay. If you focus on the content and not me, you guys are going to be fine. The next thing I want you to pay attention to on this slide is the blood glucose level. It's very important. You're going to be questioned on it. You need to know what the normal fasting blood glucose range is. And this one says 74 to 106. And the normal range, depending on the textbook that you're using, it's about 70 to 110. If you're questioned on this, there's going to be a variation of about 5 points, and that's normal. So as long as you got the 70 to 110 or within that range within 5 points, you'll be fine. Don't forget, insulin is secreted from the pancreas, the beta cells of the islets of Langerhans. Okay. The next slide, it goes over insulin and when it's secreted the most. I want to explain to you how this happens, guys. So insulin is secreted continuously, but it's secreted continuously in very, very minute amounts. And what happens is whenever you eat a food, you eat a bolus of food, the insulin that's secreted goes from the minute amount to whoosh, shoots up. Why? Because obviously if you're eating, that means you're going to be having higher glucose levels, right? Which means your insulin level has to increase because the insulin is what brings the glucose out of the bloodstream into the tissues where they need to go. So on this slide, it's very important for you to understand this, okay? You expect, this is what's supposed to happen, that even though the insulin levels are being secreted in very, very small amounts, the insulin level increases after the person eats breakfast, increases after they have a snack, increases after lunch, and so on. Every time they eat, the insulin level should go up to accommodate whatever they just ate because it's the insulin that brings down the blood sugar level. On this next slide, insulin is synthesized from proinsulin, that's your precursor. We need you to know that. All right, so let's talk about the onset of disease for diabetes. As I said, guys, I'm looking at a slide, so that's why I keep veering over to the side. But by the time you guys see this video, the slide that I'm looking at, that my eyeballs are literally veering off to the side, it's going to be a split screen. So you'll be able to hear my voice and see me if you want, but you'll be able to see exactly what I'm looking at, okay? So please forgive me, I'm new at this. The onset of disease. Again, the islet cell antibodies are present for months to years before symptoms occur. Now we're talking about type 1, guys. And how do we know it's type 1 that we're talking about? Because I said islet cell antibodies. Remember, type 1, that's the one that is an autoimmune disease. So that patient's own body is creating antibodies, and that's why that patient's not secreting insulin, not making insulin, or if they are making insulin, they're not secreting it in the amount that would keep them alive, okay? So for type 1, the islet cell antibodies are present for months to years before symptoms occur. And so what happens, those patients who are type 1, they're usually, diagnosed in early childhood, and that's where we've gotten the term juvenile onset diabetes because obviously it was patients were diagnosed with this as children. Manifestations develop when the pancreas can no longer produce insulin. Then rapid onset with ketoacidosis. That is very important for you to know, and schools love testing about it. ATI loves testing about it. HESI loves testing about it. Heck, NCLEX loves testing about it. So you have to understand this. Patients who are type 1, and I said this to you before, you're hearing me say it again, and then when I get into diabetic ketoacidosis, you'll understand it a little bit more, but those patients who are type 1, they're the ones who are more likely to go through DKA, which is diabetic ketoacidosis. That's your type 1. Your type 2s are more likely to go into HHNKS. So right now we're talking about type 1, so we're talking about the diabetic ketoacidosis. Recent history of sudden weight loss, polydipsia, polyuria, polyphagia. They require an exogenous source. Remember I taught you guys what that word exogenous meant. That means from the outside. That means Your type 1 diabetics are not producing insulin, or they're not producing near enough insulin to keep them alive. So in order for them to live, they need an exogenous source, an outside source of insulin, okay, for them to be alive. Patient may have a temporary 3 to 12 months remission after initial treatment. That's your type 1. Now let's talk about type 2. Formerly known as adult onset diabetes or non-insulin dependent diabetes. I want you to think about that for a minute. Why non-insulin dependent? Well, here's why. Our type 1s are the insulin dependents. They're the ones without insulin, they will die. Kaput, they're kicking the bucket, right? But remember, our type 2s, they don't have to be dependent on insulin. Matter of fact, they don't even have to have diabetes, right? Start exercising, start eating right, and 95 to 98% of those cases, the hemoglobin A1C goes down, and bam, they're not diabetic anymore. So that's why the type 2s are also known as the non-insulin dependent type. Most prevalent type, 90 to 95% of the people who are diabetics, this is the type of diabetes they have. The risk factors, being obese or overweight, having advanced age, having a family history, okay? The prevalence in children is due to obesity. So it used to be that the children who got diabetes is because they were type 1. They were born with some kind of autoimmune disorder. But what we're finding now that we're in the age of, I don't want to say the company because I don't want to get sued, but we're in the age of fast food where children are being obese and there's childhood obesity. And along with that childhood obesity comes diabetes, okay? There's greater prevalence for ethnic groups, and there are lots of reasons why, but very shortly I'll touch upon it. I want you to think about certain ethnic groups. They live in certain areas. There aren't grocery stores near that area where, you know, they can get fresh produce, vegetables, fruits. There are corner stores where they're, you know, being sold high sugary drinks. You have the ice cream man coming around 3 times a day, etc. And this next slide just goes over your type 1 and type 2 diabetes, and it just really gives you a picture of what that pancreas looks like, how it's secreted, and where you expect the blood sugar to actually have its most effect, or its best effect, I should say.